Thank you, Mo, and welcome everybody to our June WebEx, looking at reducing medicine time across transitions. And today we've got our guest board presentation being NHS Grampian. I'd firstly like to extend the welcome to everybody who may have already been with us over the last 2 days at the NHS Scotland event. It's fair to say it's been a fairly busy week, so we appreciate that there's probably a number of people that are otherwise occupied, but we really do welcome everybody who is able to join us today. As Mo's mentioned, this is a new format of WebEx. We've changed the way that we're supporting these meetings just to allow more people to actually join the WebEx. For those who were able to join in May, we were made aware of a number of people that actually weren't able to join purely because the number of lines hadn't reached its maximum. So we are now hosting this as an event, and there are a couple of changes in terms of the way that the WebEx will kind of function because of these changes. But again, it's a positive way in terms of we want to be able to maximise the number of people that can join. For those who've not been part of our WebEx before, really it's a chance for everybody to come together from across the whole system of healthcare, looking at reducing medicine time across transitions. So we are trying to hear from boards throughout the year, looking at what information and testing they've been doing around making medication reconciliation at transitions reliable. We do want this to be an open and honest environment. We encourage people to respect what other people say, to pay attention, and most of all, to see what they can learn and take back to their boards in terms of what they're hearing from the guest board presenter. So just a couple of things for the WebEx today. You'll note that this guidance is now updated to reflect our BT events process and the fact that all phones that are not presenting phones are automatically on mute. So there will be no option today for you to ask questions down the phone. However, we do encourage everybody to use the chat box as a way of communicating, and if you do have any questions to ask the presenters, please do put your questions in the chat box. We also do ask if you'd like to introduce yourselves as well via the chat box, to just use that function to let us know where you're working and what role you have in terms of the board that you're working in. For those who have not used the chat function before, there is the chat box at the top, which I'll show you now in terms of making sure you click on that button. And the important thing too is when you're typing into the chat box, please make sure that you do select everybody in terms of your drop-down menu. And thanks, Julia. Last month we had a number of excellent comments and questions that came through to me privately, but we do want this to be an open WebEx. So again, we do encourage you to make sure you select all or everybody when you're actually typing into the chat box. We are recording this WebEx, and we can definitely see that this WebEx is being recorded. Again, we've had a few technical issues in the last couple of WebExes where that functionality just was not working, but I can confirm that this WebEx will be made available on our website for others, and so please do promote this widely when we do finish the call. I'd like to introduce Alistair McLaren, and hopefully most people will know Alistair by now. Alistair is our National Clinical Lead in the pharmacy role for our work with SPSP medicines, and I'll just hand it over to Alistair for a few quick reflections.
Okay, thank you very much, David. Good afternoon, everyone. So one of the things I wanted to do here was try and reiterate, obviously, as a series of WebEx, I think this is our 8th WebEx on medicines reconciliation, and that in itself hopefully tells everyone that medicines reconciliation remains a national priority for SPSP medicines. It's been going for some time, I know, particularly in acute, but it's no less important now than it has been in the past. And I think the purpose of the WebEx is, as David touched on, is to share learning, not only between boards, but across healthcare settings. With medicines reconciliation really being about the interfaces of care. What I wanted to pick up on today was something that came out of a couple of the previous WebExes, was the importance of trying to learn from medication incident data that boards have been collecting through Datix or whatever incident reporting system they have locally. And I thought today would be useful just to share a sort of review of incidents within my own board area, which is Greater Glasgow and Clyde, with you, just to demonstrate some of the learning points that are there. Looking at the sort of data that we have, most of it is skewed towards the managed service because the incident reporting system is aligned to that and therefore reflects incidents primarily in the acute and to a lesser extent mental health setting. I think what was interesting looking at the incidents, first of all, is that a lot of them related to high-risk medicines, whether it was anticoagulants, antiepileptics, opioids, steroids, and so on. But broadly, the incidents could be put into three distinct categories, which I thought was worth sharing. The first one, which probably won't come as a great surprise, where could be described as medicines being omitted or missed off from a patient's prescription, either for part or all of their hospital stay. And that tended to be either because medicines reconciliation wasn't done at all, or there'd been a failure to reconcile multiple information sources. So, for example, in a couple of instances, sole use of the emergency care summary was reported. So an example there was a patient on clozapine, which doesn't appear in the emergency care summary, so wasn't picked up in the medicines reconciliation. Patient didn't get it for 3 days. The error was then detected at discharge, at which point the patient then had to be referred back to psychiatry for review and retitration of the medicine. The second category were incidents where the wrong medicine had been prescribed and given, and that tended to be either due to the use of another patient's medication history or prescribing old discontinued medicines that were listed in the emergency care summary. So, for example, we saw one case where a woman admitted to hospital, the history was taken using not only ECS but a repeat prescription slip. It turned out the repeat prescription slip in the GP practice was that of her husband, and so all her husband's medicines were written up for her. Fortunately, it was detected at review, so no harm from that one. And in another case, a patient admitted with acute kidney injury, 3-week history of drowsiness and confusion. All the drugs on the ECS were transcribed over onto the Cardex, and unfortunately included in there were sort of several opioid-based analgesics which had been discontinued some months before. But again, fortunately, the error was detected before the patient got any of the medicines. The third category I came across were wrong doses being prescribed and given due to transcription error between the medicines reconciliation documentation and the prescription chart, or again a failure to reconcile multiple information sources. So in one incident we had a patient who was written up for 5 milligrams daily warfarin. During the medicines reconciliation there was actually only on 1 milligrams prior to coming into hospital. In that case it resulted in a longer stay because the INR went off and they were held in a little bit longer for monitoring. And in another case, a patient who was written up for rivaroxaban 20 milligrams daily, which was the correct dose, that was on the MedRec form, but then that was transcribed onto the prescription chart as 20 milligrams twice a day. And unfortunately that wasn't detected for 10 days until discharge, when it was then corrected. So I think it was just to illustrate the kind of information that is there. All boards have their incident reporting systems, and I think what's interesting, these incidents highlight not only the harm that comes when MedRec's either not done or it's not done well, but also some of the new risks that we're seeing which arise from the process itself. So whether that's an over-reliance on ECS or the fact that we now have this transcription between a documentation of a medication history and the writing up of a prescription chart. And I think it's something for future WebExes, if boards have a chance to look at their data, it would be interesting to hear what other learning is happening around the country. So with that, I will pass you back over to David.
Thank you very much, Alistair, and it's always good to hear some reflections in terms of the data and the information that's available at board level for learning and sharing, so thank you very, very much. In terms of just a quick summary in terms of where we've come from, by now, hopefully again for people that are not new to the WebEx series, this is actually our 4th for 2016. You'll have heard from Glasgow and Greater Clyde in March, Ayrshire and Arran in April, and Fife last month. And again, today we've got the pleasure of hearing from NHS Grampian. Can I encourage everybody before we do move on to make sure we're using the chat box to communicate any questions that you might have as we progress. I've also received a comment through the Q&A in terms of have I muted my phone line correctly. And I just want to again reaffirm to people, this is the first time I'm using BT Event as a way of supporting this WebEx. And unless you've been pre-nominated as a speaker, your phone line is automatically muted. You'll probably notice as well, for those who've been on WebExes with us before, we've also switched off the tones and ringing bells that indicates that people are joining and leaving the conference. So again, we're just hoping that it's going to be a bit more smoother. And we've also got a very reliable recording source now that we can guarantee this WebEx is being recorded as well. So before we do move forward again, can I just encourage others to use the chat box to ask questions, but also to introduce yourselves. I have seen that some people have introduced themselves via the Q&A function, which essentially we're not looking at today. So can you please make sure that you're looking at using the chat box icon and then doing a select all to chat to everybody today. Some of the key points that we've learned to date around reducing medicine's harm across transitions at a national level, it's fair to say these haven't changed. We know that medication reconciliation is an extremely complex process. A clinical process involves a number of steps, a number of people, not at least the patient. And we've also learned quite clearly where things have worked well, it's often been due to the fact they've got significant visible senior medical engagement, particularly in the acute care setting. And we're learning continuously the way that boards are actually looking at ways to capture feedback across the points of transition regarding the quality of information that's being communicated, both to the patient as well as the other healthcare professionals. So for those that weren't able to join us last month in terms of FICE, they provided some 3 key points that, again, I think created quite a lot of interest and a lot of question. The 3 things they wanted to share that they'd be interested in sharing more with if you wanted to contact them were particularly around the use of patient questionnaires and medication reconciliation forms in GP practices. They've got experience and are willing to share their knowledge about applying for code-to-code approval to access the clinical portal, particularly in the context of community pharmacy. And they've also shared with us quite some really interesting work around the development of a post-take ward round to improve the reliability of medication reconciliation in the acute setting. So again, I think it's fair to say that a number of other boards are testing the idea of the post-take ward round, and we've got a number of other boards also looking at how they share information more reliably in the community. So, and again, we're looking forward to hearing from Grampian in terms of the work that they've been doing. Just to say too that for those that are not aware, we're providing monthly summary updates for all of the WebExes. So the 3 key points that each board provides is populating what you can see in front of you, which is our key learning document. And that, along with today's recording, will be updated and put onto our SPSP Medicine's website. So again, we just encourage you to share that with anyone that's not able to join us today. So without further ado, I would like to welcome NHS Grampian. Now I know, again, we are learning today in terms of this is the first time we've used this format. So we've got Fiona Mitchell-Hill in NHS Grampian and actually quite a number of other people around NHS Grampian helping present this afternoon. So I just want to make sure from Fiona's perspective, we've actually got all the speakers on the call.
We're starting to hear from Aberdeen. Matt, are you there from Elgin?
Yes, we're here.
Welcome. That's fantastic. So can I just confirm, Fiona, we're expecting 2 separate speaker lines for our call this afternoon?
That's correct.
Excellent. That's always good news. So, Mo, can I just ask, is it possible to pass the ball, please, to Fiona Mitchell-Hill to help with the progression of the slides for this afternoon?
Certainly. There was 1 moment.
Thank you. And Fiona, once you've got the ball, the court is yours, as they say, so we're really welcome to hear from you.
Okay, thank you very much. So as David indicated there, I'm actually joined by several of my colleagues here, which is fantastic. And I will introduce them just now. So I've got Kim Cruttenden, who's a principal pharmacist in acute. I've got Pam Thorne, who's a pharmacist in our mental health service and learning disabilities. I've got Matt Jobson, who is a quality improvement facilitator who supports paediatrics in the neonatal programmes, and I've got Louise Black, who is a quality improvement facilitator who also supports the primary care and the pharmacy and primary care collaborative. So that's the team that are going to be presenting. I'm going to say very little, thankfully, today, but I will just to start, where are we so far in Grampian? I'd say it's variable. I think some services have progressed further than others with medicine reconciliation. I think it's since we went to medicine reconciliation community pharmacy has been a big change for us, and like Fife, we had quite a lot of challenges to get that through call-to-call approval. It took us more than 6 months to get that process was delayed, waiting for call-to-call approval to get that done effectively. I think it's we're building QI capability with some of our pharmacy teams, which is fantastic, and getting to use the methodology that we would use to make a difference to our patients. I think our progress has been probably quite slow, slower than we would ever have hoped, but definitely medication safety is a priority for NHS Grampian. So I'm going to now pass on to Matt.
Hi. Thanks, Fiona. So, Fiona, is it okay if I just tell you when to move on?
That's fine, Matt.
Okay, thanks. So I'm actually going to talk to you not about a project that's not actually specifically related to medicines reconciliation, but hopefully all will become clear as we move through. But to give you a little bit of background about medicines reconciliation, specifically in paediatrics for us, it's probably a very similar story to many other boards and many other sectors within our own board. And we do collect data on a monthly basis. If you could just move on, Fiona, that's our medical data, some of our medical data within paediatrics, and this is our surgical, and pretty much similar picture really, in that it's quite variable. We usually sit somewhere around about 60 to 70% compliance on completion of medicines reconciliation within 24 hours of admission. If you could just move on, Fiona. And some of the things that we've done around medicines reconciliation over the past sort of 2 or 3 years is supporting areas to collect that data, and that didn't work particularly well, so that now sits with the pharmacy department in RACH. They collect the data for all the different clinical areas. We've looked at different ways of displaying the data and feeding that data back to medical staff, and incorporating that data and education within the junior doctors induction programme. And that gives us pockets of success, and then we tend to find, as with many other areas, that it kind of goes back to where it was to start with. And we've also, in paediatrics, we have a zero tolerance programme, which generally focuses on different aspects of medicines and safety, but we have focused several of our zero tolerance weeks on medicines reconciliation. And again, when we do that, we see an improvement in the compliance, and then it tends to slip away as junior doctors rotate, etc. So what I'm going to talk to you a little bit now is how we looked at something that was doing a piece of work that was not specifically around medicines reconciliation. That was a ward round checklist. So we've had a ward round checklist in the Children's Hospital in Aberdeen for probably about 18 months now, but again, compliance with the use of the checklist wasn't great, so we were looking at how we could maybe do it a little bit differently. And this piece of work we've done in Ward 2 in Dr. Gray's Hospital, which is based in Elgin, which is a small paediatric ward within a small district general hospital. And what we've done is looked at implementing a ward round checklist sticker. So this sticker is put into the notes, and as I'm sure you're all familiar with ward round checklists, has a variety of different elements on it as a reminder of things that need to be done and checked as part of the ward round. So we didn't just want to look at collecting data on whether the checklist was being used. We wanted to look at, well, did that actually make a difference to the patient? So we decided to choose one thing off the checklist and measure that against compliance with the checklist being used. And lo and behold, we decided to use medicines reconciliation. If you could just move to the next slide. And this is the data that we've been collecting. So I've gone in and supported the ward to collect this data, and we had a bit of a slow start so the blue line there you can see is whether the ward round checklist was used, and as you can see, the checklist is either used or it's not used. It's not that they get halfway around the ward round and decide to stop using it. If they do use it, it's used for all the patients on the ward round. And the red line there is whether medicines reconciliation was also completed. And as you can see, when the ward round checklist wasn't completed, the medicines reconciliation sat around what we find in our normal data collection for medicines reconciliation. But as the ward round checklist, the medical staff decided they liked it and started to use it consistently, we've seen a consistent improvement in completion of the medicines reconciliation forms. Now this is a very, like I said, this is a very small ward, and this is a very small data set that we've got here. But I think we can say that it's been a really promising start, and it's been a really interesting process for the ward and certainly the medical staff, and they've been very engaged with this process and really like the data that we've collected and displayed for them. So what we're looking at doing now is rolling this out into the Children's Hospital in Aberdeen on a bigger scale, and hopefully we will see similar results through there. But I think it's really interesting that this wasn't specifically about medicines reconciliation, but we've done something that we've been able to impact on improvement in a variety of ways, really. And that's me.
Yeah, super. Thanks, Matt. So now we're going to hand over to Kim, and she's going to share the evolving process in the acute hospital.
Okay, so just looking back a bit, in around August 2013, we were only really using medicines reconciliation paperwork within medical and surgical admissions. I think that's where a lot of boards started, within medical admissions in particular, but it's very much an uphill challenge to start with that sort of area, and something we struggled with for a very long time. But as we tried to spread it out with this sort of enthusiasm that was gathering, we then ended up, unfortunately, with 7 different versions of medicines reconciliation forms, which of course, as you might expect, caused significant confusion due to the variability. You know, some were landscape, some were portrait, and some were green, some were white, etc. So we've done quite a bit of work, and it's taken a while to withdraw all of these forms and get it back so that we only actually have one medicines reconciliation form as part of a booklet, or Clarkin booklet, and one as a separate sheet if there's not a Clarkin booklet used within a ward area. So it has taken a while to get to that stage. So, but as of November 2015, we did do a fairly large audit across the board, and found that, you know, of the 400 patients we looked at, 86% of patients had a form that was completed to some degree. So we've gone from, we've audited in the past, to about 10% compliance to 86. So that's a huge achievement, not as good as we'd like it to be, but a huge achievement. So that's fine. And it was just really to break down a little bit the audit that we did do in November. So of these sort of 400 patients that we looked at, there were 344 medicines reconciliation sheets that were actually auditable. But I think what's useful to look at from this is that this was just a comparison of using a booklet or a separate form, and I don't think there's anything that's really surprising in this, but we just showed that actually if the medicines reconciliation form is within a Clarkin booklet, the compliance with filling it in is much better for most of the elements than if you have a separate form. But I think that, you know, it's due to familiarity and it being where you would expect it to be. But it is useful for going forward that perhaps we need to encourage more of these booklet versions to be in place. So what we have seen is some definite improvement in the accuracy of the medicines information within the medicines reconciliation form. So looking back to, you know, when we audited in January 2014, we were looking at somewhere between 30 and 40% accuracy within the medicines section. Then in November, we did something a little odd. I asked the pharmacist to audit the accuracy of the forms themselves, and we got somewhere, you know, close to 70, I think it was 68%. Accuracy within the forms. That's a huge leap from between 30 and 40 to 68%. But then I got a researcher to go really around slightly covertly in November as well, just to sort of check to see how the pharmacists were really complying with the medicines reconciliation process, because with the definition of accuracy being that it's been checked by pharmacists, how much were they actually signing the forms? And what was interesting was that actually they only came back with a 58% accuracy rate, and that's purely based on whether the forms were signed or not. So if you're auditing outside, actually we can't achieve any higher rates if the pharmacists don't sign the form. So that was quite worrying from my point of view, and we've had lots of conversations around that and how to improve things. Next slide. But overall, our bundle compliance is improving. It's not perfect, but it is improving. But again, you know, we've got issues around people actually signing the forms. I don't think that my pharmacy team are not following the medicines reconciliation process, but we can't prove it because actually there seems to be lack of engagement and actually signing on the dotted line in the form. So we're doing some work around that, and then we're going to re-audit it. But to go from 10% bundle compliance, you know, up to 50% is significantly better, but it's nowhere where we want it to be, and I don't think it's actually a true reflection of where we are. But when you audit it, that's where we find where we are. Okay.
Thanks very much, Kim. And now I'm going to pass to my colleague Louise, who's going to speak about primary care and the community pharmacy and the challenges and the launch. Okay, Louise?
Hi there. Just to go back on to what Fiona said earlier on, NHS Grampian excuse me, has been part of a national pilot with pharmacy and primary care. And we're partners with NHS Highland, NHS Fife and NHS Greater Glasgow and Clyde. We've got 5 teams across NHS Grampian, and these consist of independent pharmacies and multiples, with 2 pharmacies working over 2 different sites. The first year of the collaborative, we looked at high-risk medicines, and NHS Grampian and NHS Fife looked at warfarin, how it was managed in pharmacy, and patient education and compliance with the oral anticoagulation therapy booklet and their alert cards. Can you move on, Fiona, please? Specially chosen. This girl's got her hair dyed to match her pharmacy bag. Hope you all noticed. Year 2, we were looking at medicines reconciliation, and again, as Fiona alluded to, we've had some real problems with this. It's taken us a long time to get an information sharing protocol signed off, and this was to allow our EIDLs from an acute setting to be shared with our pharmacy colleagues in primary care. It has taken so long that we're actually looking with or investigating with the national team about taking forward a national information sharing protocol so other boards don't have the same issues that we experienced. The pharmacy care record that's used in pharmacy had to be reconfigured by ATOS to allow the community pharmacists to see the EIDL when it was sent out. And again, this took quite a long time to be configured, but we're there now. We've also highlighted in the last few weeks that the homepage on the PCR in the pharmacy shows different homepage screens for the pharmacist signing in and for the technician signing in. And this has been taken forward to Community Pharmacy Scotland so that it can be addressed at a higher level. We've had about 14 EIDLs in the last few weeks that have been sent out to our community pharmacists, and about half of them have required further communication with the primary prescriber and then education and counselling interventions by the pharmacist to the patient or carers and relatives. The trigger in the community pharmacy is the GP time script, and then they need to wait for either the patient or the relative and carer to attend the pharmacy, and this allows them to use a second source when checking against the discharge prescription for any discrepancies that have been highlighted through the discussions. And then that's when communication started with the primary prescriber. The teams have all agreed that it's been a kind of monumental journey to get where we are at the moment. When we sat and spoke about doing medicines reconciliation in the community pharmacy, we thought it was going to be quite easy, but in fact it's, you know, it's far from reality. But we are getting there, and they wouldn't want to do anything different because they realise the benefits that their patients are getting with the community pharmacists doing this with them and for them. Move on, Fiona, please. This is just the data collection slides that we're using in the community pharmacy, and this data is being collated. Supposed to be looking at 5 patients a month, but because our numbers are so small, we're actually looking at every EIDL that we're getting coming into the pharmacy at the moment, and communicating back to GP practices if need be. Last slide for me, Fiona. Just a bit about medicines reconciliation in general practice. It was part of our health board specific work last year in the GMS contract, and practices could choose to either do it or not. We found it really difficult to get data from our primary care contracts team around who actually signed up for this, but we did have 14 practices in Aberdeenshire make an agreement with their medicines management contract, and they did a year of medicines reconciliation data collection in practice, shared that monthly, and made improvements in their processes and practice, and this is where we are. We're sitting about 84% compliance, 86% compliance, which is better than where we started. There's still a lot of work to do. Some of them are still actually doing medicines reconciliation and just using the data themselves in practice because it's no longer part of their contract work to do, but they feel they've still got steps to improve. That's me.
Yeah, super. Thanks very much, Louise. And now I'm going to hand over to Pam Thorne, who's going to talk about how they've made it happen in mental health.
Hello. I just want to give a little overview of mental health in Grampian. We're a small team of 5 pharmacists. We cover 40 consultant psychiatrist-led MDT teams across 18 wards. And our patient group are different to the patients maybe coming into acute. Admissions are often unplanned and out of hours, and patients can initially be really too unwell to give information about medication and unlikely to have brought any medication even with them. Length of stays tend to be longer, quite often people can be in for several months or even years. We started using MedRec forms in 2012 with a pilot on 1 ward, and then moved that onto the 4 admission wards once we developed the form. But we did find that we really only got consistent use of the MedRec form when we rolled it out across the whole hospital, because with the patients being admitted quite often out of hours, the doctors that were doing the admission were quite often not involved with the pilot wards, and so weren't aware of the MedRec forms initially. So the slide that we've got there shows the audits that we've done since it went across the whole hospital. Initially, when new doctors come to the wards, at the doctor's induction, they're given information about medicine reconciliation, and then a few weeks after they've started, we give feedback to the individual doctors on their use of the MedRec forms and any problems that we've picked up. And we tie in an audit based a couple of weeks after the new doctors have started. And the information from that audit, we look at a 2-week period. All the patients that are admitted right across the hospital during that 2-week period, we look at whether MedRec forms are done and how well the forms are done. And then that information also goes out in email form to all the doctors. And what we also do is a written report of that audit, which goes out to the ward managers, and that also has a chart showing what the results for each ward are, so that we can get a bit of competition between the wards to see how well they're doing. and also to encourage the ward managers to make sure that MEDRC forms are available on the wards easily. Obviously, a lot of our doctors doing admissions are not based on the ward. They might be the duty doctor, the doctor that's covering overnight or at weekends. So that really covers how we're doing it. So this is just the feedback that I've mentioned. Obviously, each time a MEDRC form, for every admission, the pharmacist looking at the MEDRC form initially will prompt if there's no form being completed. And we also put summaries to leadership groups so that it's not only the junior doctors that are receiving feedback, it's all the doctors. That covers it.
Super, thanks very much, Pam. And now we're just about there, so we just want to share some of our successes and challenges, and Kim's going to give you that feedback.
I think something that's quite significant just in very recent times is that although we've been reporting sort of data not unique to Grampian by any means, but you know, the average error rates in prescribing associated with medicines reconciliation or during admission or on discharge, we finally seem to have actually reached a point where we've got really high level engagement with this and support from the management team within the hospital. And we had some very high level meetings around this. So we've got some plans in place and certainly buy-in from them for improvement on a number of fronts. And we're hoping for, you know, across the board engagement in this rather than let's just pick off individual wards and try and make, you know, make small improvements. But we're looking at things like, you know, we think that we need to have some individualised feedback on prescribing around medicines reconciliation or around any prescribing really to prescribing staff who are on the whole mostly still medics. But to do that, we actually think we'll run a zero tolerance, but on a very simple scale, as in zero tolerance around not printing your name on the medicine chart, because at the moment we can't identify Dr. Squiggle, and it's very, very difficult to feed back to individual doctors when they're not around. So it's how we're going to tackle that so that we can actually give individualised feedback around prescribing, around MEDRC, etc., to actually make some real improvement and really get to the bottom of this. So, and then of course, as I mentioned before, we're looking at, you know, the standardisation of paperwork. Sorry, that's certainly been achieved. And then, as Louise mentioned, the discharge letter going to community pharmacies will hopefully only just grow. And then we're also, some of the challenges that we're still having is around ensuring staff, and that includes pharmacy staff, that includes my team signing these medicines reconciliation forms and accepting responsibility for seeing them. So that is still a bit of a challenge. And then indeed moving medicines reconciliation now to the pharmacy court, because as much as I've been trying to push it away to a point and for it not to be just a pharmacy thing, it still remains with pharmacy really pushing it along, and we struggle to get champions within the wards, and the auditing at the minute is done by pharmacy team or me putting in someone who's connected with pharmacy to audit, so it's still a challenge.
That's super. So just our key points for sharing. I think it's not an easy process. I think every board would say that. It certainly varies across our organisation, although it is a priority for the organisation, which also raises challenges. We're a bit like Fife. We've also found that kind of post-take or the structured ward round, admission booklets and that are having an impact on our medicine reconciliation and improving our compliance, which is great. And we're encouraging other areas to use that sort of template to encourage, because obviously there's a knock-on effect not just for medicine reconciliation but other documentation. I think overall we are absolutely making progress, which is fantastic. I think there is much more buy-in at a senior level now than we've had in the last few years. Other than like mental health, they've been bought in, I'd say, for a couple of years there easily. So I think they are further ahead than some of the other services. We were also asked what we'd like to know. So we're quite keen to know about electronic records. We're nowhere near that in Grampian, sadly. But I just wondered if anybody out there is using them and how's that improving compliance with medicine reconciliation. And although we have got the Caldecott permission about the sharing with community pharmacists, it still remains a bit of a challenge how we can reach our 131 community pharmacies we've got. And I wonder if anybody's got a process for sharing that information across the whole system. And that's us. Thanks very much, David.
And thank you, Fiona, and thank you for all of the speakers around Grampian. Thank you for joining us in both sites to share with us the work that you've done to date. I do apologise for those that are using the chat box. It may appear that there's been absolutely nothing happening in the chat box from your view, but I can tell you there's been lots of questions coming through. We need to obviously sort out for our next WebEx how we might make the entire chat box visible to everybody, but we do have a number of questions. And I guess if I can start, and it may not be to answer just now, but it might be to reflect on the various aspects of the different areas that are working on medication reconciliation specifically. What local aims do you have in terms of how much by when in each of the various areas? Fiona, I know you mentioned before that the various stages of kind of progress in the different areas of mental health, community pharmacy, GP, etc. So in terms of making an improvement and making people strive to make a difference, it's a question we'd ask everybody on the WebEx today. What is the local ambition statement around that improvement aim? What is the how much by when for each of those areas to give them some kind of goal to work towards? We've just noticed that at a national level it's been quite hard for us to describe or even define one based on exactly what you've shared today, that all areas seem to be at different stages of progress. Fiona, I don't know if you want to comment on that at all.
So I think it would be easier for us to pin down on our hospitals about our how much by when. And we just had a bit of a chat, and we don't think we should stretch ourselves and say we'd be looking for the kind of 95% compliance by the end of the year. I think it is harder for our primary care colleagues with the changes to contracts and such like, and also our community pharmacists, because it's taken us 6 months to get it to 5. So to get to 131, I think it's going to take us a bit of time. But certainly from our acute hospitals, that's going to be what we're aiming for.
Brilliant. Thank you for that. And I guess it's a question to everybody else on the call as well, because it's fair to say when we're looking at this from a whole system approach, every part of the system is potentially going to be at a very different stage. So it's just being aware of what the local ambition or goal will be to help make people feel wanting to make a difference and get to that goal. If we do use the chat box, and again, everyone else on the call, you have to forgive me for my voice being the person that's asking the questions, but I can promise you they're not all from me. We're just going to scroll through. I think, Matt, the first question is for you. One of our attendees has asked for a little bit more information about what actually happens during the zero tolerance weeks.
Okay, so we actually just ran a zero tolerance week in paediatrics last week. So really what we do is we communicate widely what is going to be the theme for that week, and that's communicated on a poster. So, for example, last week it was exactly what Kim has just described, that we were having a zero tolerance to any prescription that didn't have a printed name with it. And then each ward has a data collection tool, which is simply that if they have to speak to one of their colleagues that they have reached the zero tolerance criteria, and they make a mark in the appropriate box on the data collection, and then we look at whether over the course of the week there's been an improvement. That's kind of it in a nutshell. What we've run, I think that was our 6th one that we've run in paediatrics, and each one that we've run, we do see an improvement over the course of the week from the data that we're collecting. I hope that answers the question. It's quite difficult to describe without having sort of visuals as well. I'd be happy to share any information if that was needed.
Thank you. And I was going to say, I know you've shared a little bit about your zero tolerance approach before and at previous learning events as well. So we'd be keen to sort of share that again as well. Just looking into it, does look like our glitch has been rectified towards the end of our WebEx, which is fantastic, which means that if anyone else does have questions to share with everybody, you'll be able to select all participants in the chat box, which means everybody will be able to see what you're asking. However, there are still a number of questions that have come through that I will get back to. Arvin's asked, particularly around the acute setting, I believe, is the MedRec version of ECS used in Grampian? So do you have the electronic MedRec form available via ECS up in Grampian?
No, we don't.
No, we don't. Okay. So, Arvind, I'm not sure if that actually leads you to another question, but I guess we've got the answer first up in terms of what that actually means for you. There was the next question was for Kim in terms of the data around the acute adult or work that's been happening, or at least the acute care data. And it was just more of a question of the availability of more frequent data. It was noted that in terms of data over time, the paediatrics and mental health are sharing data on a monthly basis, but it was noted that the data that's been shared from the adult, or at least the acute side, is actually annual audit data. And they were just wanting to explore, are there monthly kind of time series available?
So we do have, so obviously we report nationally on for the acute programme on medicine reconciliation. So we do have some for some wards, but obviously this is quite, we don't have a system that captures it for us, so it's just relying on people either feeding us the information or us going out and getting the information ourselves. So we do have some, but it's only for a few wards. It's not for the 49 wards I think we have in acute.
No, we have some individual wards who pharmacists are capturing the data on a monthly basis, but we're trying to gather that it's the overall picture. It's a lot of work to do the whole hospital. In fact, we do that's just the ARI data that we had, but we have Elgin Hospital, Children's Hospital, etc., which is separate data. But we try and do it at least annually for that purpose. But with engagement with the management within the hospital, we agreed to do that with more frequency, and also to, within individual ward areas, to try and feed more on the prescribing data on more of a regular basis into M&M meetings, etc., which is providing us quite a good forum to raise issues.
Excellent. No, that's good to know, and I think that was, the question was coming from I guess, an improvement kind of approach of the more frequently you look at the data, the more opportunities there are to learn. But I do appreciate what you presented in terms of the annual data. It does sound like an aggregated hospital-wide measure. But I guess what we're looking for is, I guess, what's happening at an individual ward level to learn what's working well and what's not, to be then shared across the wider sites. I think that's probably where the foundation from that question was coming from. We do have a couple of other quick questions as well, and Fiona, I might have the pleasure of putting the last question to you as well, just to warn you before we do get to that. But there was a question from Brian McGurn, and it is around the data that was presented looking at the ward round checklist. And Brian's commented the 100% use of the checklist is absolutely brilliant, but was wondering why that didn't necessarily correlate to 100% compliance with Meds Rec. So the question is, why do you think there is that mismatch between the 100% use of the checklist versus the non-100% Meds Rec compliance? And was wondering if you've got any plans to actually address that. What kind of things have you tested? And have you actually tested the use of that ward round checklist in acute care as well? So there's a couple of questions in that one.
So Matt, do you want to go first?
Yeah, sure. So the 2 points, once we've got to 100% compliance reliably with the ward round checklist, you're quite right, there's 2 points where we're actually only 80% compliance with the MedRec, and those 2 patients were actually patients that were under joint care, so they were both being cared for both by medical paediatrics and either a surgical or orthopedic speciality as well. And I think I'm kind of surmising, but I would imagine it's because somebody's not, one or the other has not taken responsibility for completing the medicines reconciliation form. So I think the improvement there is that we need to, the focus has very much been on medical paediatrics in this particular improvement project, but we need to roll that out now and make the specialities out with the children's ward. So the adult specialities that visit need to be aware of that as well.
Brilliant. Thank you for that. And are there any plans, and again, and I'm not talking about hospital-wide, but are there any plans or have there been any testing of that post-take ward round checklist in the acute setting in terms of any pilot wards or work like that?
So yeah, we have, David. We've got several wards now doing either a post-take checklist or structured ward rounds, and we are certainly starting to see meds and reconciliation compliance improving in that area.
Brilliant, and thank you for that. And it is fair to say that this post-board round checklist is something that a lot of boards have been commenting on in terms of what they're testing or piloting. And I know in Lothian there's some data as well that they've been looking at, even how much time that's potentially saved in terms of using the checklist. So it's information I think we'd be really keen to learn more about. But again, to be sharing that whole concept of the impact of using a post-take checklist to get this process reliable. I will move to a comment, and I think it's reflecting on what was shared in terms of the community pharmacy work, and it's from Claire Morrison, and I'm hoping, because it was shared privately with me, I'm assuming it was meant to be for everybody, so Claire, forgive me if it's not, but Claire commented that she totally agrees with Louise that the medication reconciliation in community pharmacy is so much harder than we thought it would be. They've got some great examples of where it's made a difference, but still haven't got the processes right. I think she's reflecting quite honestly that they're still continuing redefining what the community pharmacist's role should be and what they should be doing and when. And I think thank you for your honesty and reflections on that. So Claire is from NHS Highland, and it's one of the other 4 boards that are actually participating in the pharmacy and primary care pilot. So thank you for that comment. The only other comment I think that was made in relation to the fantastic information that's been shared is just in terms of some of the actual interventions or tests of change that were actually made on those run charts. So just in terms of to be able to annotate what happened when, to see what changes over time were due to what particular test of change. It's fair to say, I know you've covered in a really good level of detail the types of things that have been happening in Grampian, and it's just the idea of using the run charts to tell that story. So that was just a comment from another person on the call. The last question I want to put to Fiona actually is the question you've asked everybody else, and it's the fact that you've said, have you got anyone got a process for sharing information across the whole system? And I guess what I'm keen to ask you, Fiona, and others on the call from Grampian, what kind of mechanisms are in place within NHS Grampian to have an oversight of all of the data that you've just shared with us today? Because it's fantastic that you've got the information coming in from paediatrics, mental health and acute care, community pharmacy and primary care. But I'm just wondering if there's any kind of infrastructure group or oversight of all that data coming in as a whole system.
So we in Grampian have a monthly leadership meeting. So that's with our executive lead, oversees that, he chairs that meeting, and we take data there. I might well share this presentation because I haven't actually ever pulled it all together like that. Okay,
well, happy to help. I'm glad that this is one thing that's facilitated that as well. That's fantastic. But can I just ask, now that the chat box is working, it does look like there's an ability for everyone to ask any final questions. So if there are any, please do use this opportunity, because we will be saving all of the chats, and if there are questions that we've not been able to ask today, we can put that to our friends in Grampian for consideration after the call, just as we did with Fife last month.